This is Randy Schell, and I'm making a video cast on general clinical topics, ortho and fluids. It's part of our anesthesiology keyword review at the University of Kentucky Department of Anesthesiology. Let's first look at the keywords related to orthopedics and anesthesia. They can be grouped under embolism, air and fat, tourniquet, deflation, inflation, some of the metabolic effects, complications of orthopedic surgery like postoperative blindness, compartment syndrome. The regional topics will be covered in another video cast. Air embolism is the first topic. If there's a vein open above the level of the heart, air can be entrained. Shoulder surgery, such as the beach chair position, can put the patient at risk for air embolism. Prone spine surgery, where the spine veins, when they're open, are above the level of the heart. Cervical spine surgery, when you're up in the sitting position. And even hip surgery in the lateral position can put a patient at risk for air embolism. The bubbles that are entrained can actually go in and occlude the pulmonary vasculature. When the pulmonary vasculature is occluded, there is an increase in dead space. In other words, you continue to ventilate alveolar units, but blood's not being delivered to them. So you have a sudden and abrupt decrease in end tidal CO2, for example, from 35 down to teens. There's also an increase in pulmonary artery pressure, and right ventricular airlock can occur without forward flow, with decreased cardiac output and hypotension ensuing. If an air embolism is suspected, you should inform the surgeon, flood the surgical field with saline, so that saline rather than air is entrained, support the cardiovascular system with drugs as needed, and lower the site of that open vein if possible. Get it below the level of the heart. Up at the top right is a graphic showing monitoring for air embolism, things like end tidal CO2, TEE for some types of surgeries, and Doppler for some types of surgeries, mainly neurosurgery where we use those type of monitors. But the amount of air necessary to cause problems is shown in the graphic there. As the volume of air goes up, things like initially you just see it on TE, then you can hear it on Doppler, then the pulmonary artery pressure goes up, the end tidal CO2 drops, then cardiac output goes down and CVP rises, then the patient becomes hypotensive with electrocardiographic changes, and the classic possibly mill wheel murmur that can occur with massive air embolism. Fat embolism syndrome is the next key word, and it's classically associated with long bone fractures about 12 to 48 hours after the fracture, and can also occur with reaming of femurs during hip surgery. There's some major and minor criteria for fat embolism syndrome. The major criteria include axillary petechiae, which the picture on the far right attempts to show, and hypoxemia, PaO2 less than 60 millimeters of mercury on an FiO2 of less than 40%. CNS depression, and some minor criteria like tachycardia, fever, retinal fat emboli, and urinary fat globules, and even decreased platelets. So the classic is the petechiae in the axilla, and hypoxemia and CNS depression. The treatment is early stabilization of that fracture so it stops releasing those fat emboli, support the respiration. Steroids are controversial, and heparin and dextran, which had been used in the past, have been shown not to be effective. The next topic is venous thromboembolism, major cause of death after total joint replacement or trauma to the lower extremities. So prophylaxis is very important in orthopedic patients. 40 to 80% without prophylaxis will have venous thrombosis, and about 1 to 28%, I know that's a large range, but that's what studies have shown with clinical or laboratory, such as D-dimer evidence of pulmonary embolism. So without prophylaxis, lots of venous thrombosis, and some percentage of those will go on to develop pulmonary emboli. And fatal venous thromboembolism occur in about 0.1 to 8% and is highest in surgery for hip fractures. What are the signs and symptoms of venous thromboembolism? If you're awake, acute dyspnea, breathing fast, pleuritic chest pain, saturation dropping. If it's intraoperative, sudden drop in blood pressure with a drop in saturation and a decrease in end tidal CO2. There is a increased PaCO2 end tidal CO2 gradient such that if you draw blood gas, your arterial CO2 is high at the time that your end tidal CO2 is very low from the dead space ventilation occurring from that thrombus blocking blood flow to alveolar capillary units. The right ventricular systolic pressure can go up because blood flow is blocked leaving the right ventricle. CVP can rise, tricuspid regurgitation can occur, and RV function decreased. And the picture on the right is an attempt to show what a heart might look like who is being forced to beat against an embolus or thrombus sitting out in the pulmonary artery. The right side is dilated, tricuspid regurgitation occurs, and the left side is underloaded and small. The diagnosis of venous thromboembolism can be made with echocardiography, although frequently you don't actually see the thrombus sitting out in the pulmonary artery. Arterial blood gases, D-dimer is a specific blood test to show fibrinolysis. CT and angio, the classic tests for thromboembolism. The next key word is tourniquet management. A tourniquet on the thigh, usually it's inflated to about 100 millimeters of mercury above the systolic blood pressure, and if it's on the arm, about 50 millimeters of mercury above the systolic pressure. We usually don't want that tourniquet to remain up more than about 2 hours maximum because after that it's associated with neurologic and muscle injury. There are some absolute contraindications to tourniquet management. A sickle cell patient, if you put up a tourniquet, that extremity becomes hypoxic, low oxygen levels, and the red blood cells will sickle. Severe peripheral vascular disease, patients who are having ischemia in the operative limb. There's some relative contraindications like an existing peripheral neuropathy, a dialysis graft, an infection in the operative limb. When you inflate the tourniquet in an awake patient, over time they develop tourniquet pain. A gradual increase in blood pressure often occurs. A dull, burning, deep, poorly localized pain carried by C fibers is present. Up to 2/3 during limb surgery and 30 to 60 minutes after inflation is when it characteristically occurs. So how do you manage tourniquet pain? Well, deepen the anesthesia. You can give IV analgesia or sedation. Ketamine can be used. A double cuff, decreasing one cuff and inflating the other one. Before putting the tourniquet up, you can do intercostal brachial and musculocutaneous nerve blocks for the arm, and deflation of the cuff is definitive treatment. Tourniquet inflation, deflation, pathophysiology is the next key word. When you inflate the tourniquet, there's a rise in volume and systemic vascular resistance, such that the blood pressure goes up, the CVP goes up, and over time, there's a temperature reduction in that non-perfused limb. As the blood sits there, blood also sitting there passively, there's anaerobic metabolites being produced, acid building up. Now, when the tourniquet is deflated, there's a sudden decrease in volume and systemic vascular resistance, such that the blood pressure drops, the CVP drops, and there is a decrease in core body temperature as that cold fluid from the lower extremity mixes with the warmer fluid in the core of the body. There's also an acute rise in end tidal CO2 because the muscle undergoes metabolism in an anaerobic environment, and carbon dioxide and acid has been produced. And there's a transient increase in end tidal CO2 when the cuff's deflated. Oftentimes your end tidal CO2 will be 35 and suddenly it will jump up to 50 for a short period of time immediately after the cuff is deflated. Now, if a patient had problems with intracranial pressure, such as a traumatic brain injury along with a tourniquet being inflated for some type of extremity surgery, you can see how releasing that tourniquet could raise the end tidal CO2, which would raise cerebral blood flow and could potentially transiently increase intracranial pressure, which would be a bad thing. Also with deflation, potassium goes up. It is increased in that lower extremity over time, and along with the increased potassium, you can get acidosis and a decrease in bicarbonate as you deflate the tourniquet. Peripheral Compartment Syndrome is the next topic. Acute compartment syndrome is when you have a fascial structure that prevents the expansion of tissue volume to compensate for an increase in fluid, and that fluid can be edema or blood, often after a fracture. In the anterior compartment of the leg is the number 1. We can also have forearm compartment syndromes. How does it present? Pain out of proportion to the apparent injury, and the 5 P's are things that you should think about. Often there's a pulse present. In fact, loss of pulses is a very late finding of peripheral compartment syndrome. It becomes white color. There can be paralysis of the muscles, paresthesia, severe pain. So think about those 5 P's when you're diagnosing acute compartment syndrome. Do not depend on whether there's a pulse present or not, because loss of that pulse will be that late finding. Compartment measurements can be made, and the needle being placed in the anterior compartment of the leg is shown in the top picture. Capillary blood flow is compromised when the tissue pressure increases to within about 25 to 30 millimeters of mercury of the mean arterial pressure. So as that compartment pressure rises closer and closer and closer to the MAP of the patient, blood flow to the tissues becomes inadequate over time. Acidosis can occur, swelling can occur, pain may develop as the tissue pressure reaches between 20 to 30 millimeters of mercury, and the difference between the diastolic blood pressure minus the compartment pressure is called the ACS delta pressure. And orthopedic surgeons will often use that delta pressure as an indication for need for fasciotomy. So high compartment pressure, need for fasciotomy. Next topic is methyl methacrylate or bone cement. Bone cementing process is associated with high intramedullary pressures. As you push that cement in, or hammer it in even, there can be cement, fat, air, or even bone marrow that embolizes. But the methyl methacrylate glue itself undergoes an exothermic reaction, so it gets very hot, and profound hypotension can occur when the methyl methacrylate is put in during surgery. Profound hypotension and circulatory collapse, less than 5% of total hip arthroplasties during cementing does it occur. Etiology is incompletely understood. One etiology that we believe is absorption of the volatile monomer of methyl methacrylate actually causes vasodilation. There's also embolization during the reaming that could cause the hypotension. Lysis of red blood cells or the marrow can occur from that being very hot, that exothermic reaction. So there's some bad things that can occur with methyl methacrylate. Profound hypotension is the one we often think about, as well as the heating up that occurs within that bone. The treatment for methyl methacrylate problems is make sure they're hydrated and make sure they have adequate inspired oxygen concentration delivered to them during the time of cementing, to minimize the hypotension and hypoxemia that can accompany cementing of the prosthesis. We often avoid nitrous oxide during the cementing, which will allow us to deliver a higher FiO2 and will also decrease the risk of an air emboli if it occurred expanding. Perioperative blindness or ischemic optic neuropathy is the next topic. ION can be unilateral or bilateral. It's painless, and it's classically associated with spine surgery. It can be anterior variant or posterior variant. The anterior variant, the picture is shown on the far right of what it would look like in the back of the eye with a pale optic disc and edema. And with posterior ischemic optic neuropathy, the problem is ischemia of the optic nerve behind the disc, and so you don't even see anything if you looked in the back of the eye, and the optic disc would appear normal. The risk of ION goes up with prone procedures, spine procedures, under long GA with large amount of blood loss in the male sex and obese patients is the classic risk factors. The recommendations from the American Society of Anesthesia Practice Advisory is mix some colloids in with your crystalloids to maintain your intravascular volume. There is no specific transfusion threshold, although we worry that as someone gets anemic, there won't be as much oxygen content and oxygen delivered to the back of the eye, for example. And make sure that the head position is appropriate. If the head is down below the heart, That's not a good idea. Keep it in a neutral position, not below the level of the heart. Rheumatoid arthritis and Atlantoaxial subluxation. Anterior subluxation is quite common in patients with rheumatoid arthritis, and the picture at the far right shows a subluxation. When the distance from the anterior arch of the atlas to the odontoid process is greater than 3 millimeters, we call that anterior subluxation. There's a risk of cord injury during laryngoscopy. And you think, well, is extension or flexion worse? And actually, neck flexion is worse than extension for causing compromise of the spinal cord in these patients with anterior subluxation. Patients with rheumatoid arthritis can have compromise of their airway for several reasons. The cervical spine can be at risk for this subluxation. The temporomandibular joint may be involved and not move as well. Even the cricoarachnoid joints may not move as well. So ankylosis of the cervical spine with fixed flexion deformity, TMJ involvement, hoarseness and obstruction from cricoarachnoid involvement. You can see why patients with rheumatoid arthritis can have a difficult airway. Let's move on now to fluids in anesthesia, and the key words can be summarized under several major topics: physiology and fluid types, colloids versus crystalloids, some of the complications of fluids, and then some clinical applications. So let's move right into our key words now. Fluid physiology. The glycocalyx is on the luminal side of healthy blood vessels, and an intact glycocalyx is important. Crystalloids pass right through, colloids are held back, and the picture at the far right shows a blood vessel with the vascular lumen on top, the endothelial calyx next, and then the endothelial cell. And you can see that that calyx is kind of sitting between the vascular lumen and the endothelial cell. Protecting it by limiting surgical trauma and avoiding intravascular hypervolemia seems to be important. Starling's law of the capillary says that there is a balance between hydrostatic pressure pushing fluids out of these blood vessels and oncotic pressure that pulls fluid back in. And the picture at the bottom right shows an arterial, blood coming in, hydrostatic pressure pushing fluid out, osmotic and oncotic pressure pulling fluid in. The filtration coefficient in Starling's law is referring to how leaky the vessel wall is, and that's also a factor in the balance of fluids beyond just hydrostatic pressure and osmotic and oncotic pressure. Body water and osmolality is the next topic. Body water, the normal adult, is about 60 to 70% water. That means that if you're a 70 kilogram person, 60% of that, we're about 42 liters of water. This percentage of body water decreases as we get older, and it's lower in obese patients and lower in female patients. So in the graphic on the far right, you can see body water. Extracellular is about a third, intracellular is about 2/3, and in the extracellular space, about 25% interstitial, 8% plasma. Normal osmolality of the body is about 285 to 295 milliosmoles per kilogram. Most of that osmolality is contributed by sodium, and we can use the equation 2 times sodium plus glucose over 18 plus BUN over 2.8 to estimate osmolality. So you can see if someone was severely hyperglycemic or severely uremic, how increased osmolality could occur. But sodium, by far, is the main factor in determining osmolality. IV fluids, D5W is very hypoosmolar. 0.9 saline is hyperosmolar. It's 154 milliequivalents of sodium. LR is considered isoosmolar, and hypertonic saline, or 3% saline, is very hyperosmolar with about 900 milliosmoles per liter. The graphic on the far right is also trying to show percent of water in the human body at different ages. In the baby at birth, very high percentage of water, us the 70%, and then as we get very old in the 50 to 60% range, or heavy, obese females heading down towards that 50 to 60% range of body water. Fluid types and components. Let's look at normal saline first. 154 milliequivalents of sodium, 154 milliequivalents per liter of chloride. So very hyperchloremic and lots of sodium and hyperosmolar, 308 osmolarity. As opposed to Ringer's lactate, which has an osmolarity, isoosmolar, about 274, lactate of 28. Lactate, as you probably know, is metabolized to bicarbonate, as is citrate. And if you look at D5W, the osmolarity is below or hypoosmolar to normal, 252. And albumin can have a varied amount of sodium in it, 145 plus or minus 15. It has some chloride in it, and it tends to be hyperosmolar. Hetastarch isn't used very much anymore because of the perceived risk of these carbohydrate molecules causing renal insufficiency in certain populations of patients. Crystalloids versus colloids, it's that healthy glycocalyx which limits colloids to the intravascular space. If you cause intravascular expansion, hemodilution can occur. Colloids, such as 5% albumin, if you give 100 mils of 5% albumin, it expands the intravascular space about 100 mils, as opposed to crystalloids like lactated ringers and saline, where if you gave 100 mils of lactated ringers, about a third of that stays intravascularly, or 30 mils. Albumin is very important for maintaining the oncotic pressure, while sodium, as we pointed out earlier, is the main component of the osmotic pressure. Both colloids and crystalloids, when given in large amounts, can dilute the coagulation factors and the platelets during ongoing resuscitation. There's little difference in the efficacy between the two, except in very special situations. Hetastarch, there's issue with coagulation in the kidneys. Hetastarch reduces factor 8C and von Willebrand factor and can cause a dilutional coagulopathy when it's given in large volume. But albumin can cause a dilutional coagulopathy also. There's a recommendation that if you use hetastarch, you should not exceed 20 mils per kilogram in a 24-hour period, and there has been some worries of hetastarch being associated with renal injury in critically ill patients, and it tends not to be used in a cardiopulmonary bypass prime anymore, as it used to be used in the past. Some complications of crystalloids: saline. Very high levels of chloride in 0.9 normal saline. 154 milliequivalents per liter of chloride, 154 milliequivalents per liter of sodium. So you get a hyperchloremia. This anion causes a decrease in the strong ion difference. Strong ion difference is the difference between the cations and the anions. So if you're given a lot of chloride, an anion, normally cations minus anions is about 40, the strong ion difference, and it becomes narrower or decreases the strong ion difference. Well, we need to maintain electrical neutrality, so if you're given all these anions, you got to come up with a cation somewhere, and so water dissociates to hydrogen ion to maintain electrical neutrality. So if you give tons of saline in a large volume resuscitation, you can get hyperchloremic metabolic acidosis. Lactated ringers, lactate's metabolized to bicarbonate by the liver, and large amounts of lactate given can cause a metabolic alkalosis if you have a functioning liver. Calcium that is present in lactated ringers can precipitate citrated blood infused through the same line. Packed red blood cells have citrate in them to chelate calcium so that packed red blood cells will not coagulate. Now, if you combine lactated ringers with citrated blood, you may get microprecipitates. There's only about 130 milliequivalents of sodium in lactated ringers, and you can get hyponatremia if large amounts of lactated ringers are given. And there is some potassium in lactated ringers that in patients with renal failure, this may be detrimental. D5W, hypoosmolar, and if you gave it to a patient with, for example, a traumatic brain injury, you could increase brain water. Also, the glucose levels If they go up by giving D5W, you can worsen ischemic brain injury. So we tend to avoid dextrose-containing solutions in patients with stroke and traumatic brain injury. And glucose load can precipitate skeletal muscle paralysis in those rare patients with hypokalemic periodic paralysis. Because as you give glucose, the glucose level goes up in the patient, and the insulin then goes up. And then, as the insulin goes up, it drives potassium into the cell. And that low potassium is associated with the periodic paralysis in patients with hypokalemic periodic paralysis. Some clinical applications. How do we assess volume status? We use urine output, blood pressure, cardiac output. We can look at left ventricular end diastolic volume on echo. We can measure pulmonary capillary wedge pressure or occlusion pressure, CVP, and heart rate as a reflection of volume status. Another is fluid responsiveness. There's some evidence that these dynamic parameters, such as stroke volume variation, which is shown on the top right, and pulse pressure variation, are better at predicting response to fluid loading than is your actual static measurement of, for example, central venous pressure. One thing that you can do is raise the legs of a patient and look what happens to stroke volume or blood pressure. Raising the legs is like giving a bolus of fluids, and if stroke volume goes up and blood pressure goes up, it's probably a good indicator that the patient will respond to a fluid load with an increase in stroke volume and blood pressure. If they didn't, you can drop the legs and fluid would be back in the legs. Heart-lung interactions during mechanical ventilation. If you have a patient who's positively pressure ventilated at tidal volumes that are at least 8 mils per kilogram, you can use some of these heart-lung interactions to try to determine what's going to happen if you give them fluids. For example, pulse pressure variation, stroke volume variation, and the size of the vena cava. Pulse pressure variation up at the top, you can see as inspiration occurs with positive pressure ventilation, look what happens to the pulse pressure. Pressure goes up. Why? Because the positive pressure ventilation, lungs go up, squeeze the blood vessels in the thorax, increasing blood to the left ventricle for a short period of time, and both stroke volume and pulse pressure max go up. But over time, that positive pressure ventilation breath, what happens is that the right ventricle, which during a rise in intrathoracic pressure doesn't get as much blood, cardiac output decreases from the right side, and eventually the left-sided volume goes down. And so initially with a breath in, squeeze the blood vessels, left ventricle has more blood in it, stroke volume goes up, pulse pressure max goes up, but then it goes down with expiration. You can also look at the vena cava and the changes in the size of the vena cava. And with positive pressure ventilation in a hypovolemic patient, as you inspire, you can see the change in that IVC on the bottom right. So big vena cava that doesn't change with respiration would say, oh, that's a plump patient with lots of fluid. A small vena cava that changes a lot that varies a lot with respiration would say, that patient probably needs fluid. What is the Bainbridge reflex? That's the atrial reflex that says that if the atria is stretched or filled a lot with fluid, it says, I need to empty more because I'm too big, and the heart rate goes up. So Bainbridge reflex, stretching the atria, lots of fluid in it, causes a tachycardia. Some other clinical applications, burns. Crystalloids are usually used during the first day because colloids can leak out and cause more edema. The Parkland formula is often used for a patient with burns. That Parkland formula says we give 4 mils of crystalloid per kilogram per percent burn over the first 24 hours. And the first half of that volume that is calculated to be given over the whole 24 hours, you give half of it in the first 8 hours, and then the next half over the next 16 hours. So we could take an example of a 20% burn in a 70 kilogram patient. You'd say 4 mils times 70 kilos is 280, times 20 is 560 If you carry that out, that is 4 mils times 70 kilograms is 280, and then times that by 20, and you can see that that's over 5 liters of fluid, and you'd give half of that in the first 8 hours. Traumatic brain injury, or TBI, the goal is to maintain intravascular volume, blood pressure, cardiac output, while avoiding brain edema and avoiding increasing intracranial pressure. And one of the ways to do that is maintain osmolality of the blood, and sodium is the main component of osmolality. We avoid hyperglycemia because D5W, if we administered that, would increase the glucose, and if D5W was the resuscitative fluid, it would also decrease serum osmolality because of its hypoosmolar composition. Hypertonic saline occasionally is used, which is 3% saline with an osmolality of 900 in an attempt to decrease intracranial pressure, and mannitol is another fluid that can be used to decrease intracranial pressure. This ends this videocast on miscellaneous clinical topics number 2. Here's a quote that I love: the more that you read, the more things you'll know. The more that you learn, the more places you'll go. Have a great day and keep studying.